is a small group, so thanks very much, everyone. And please, let's open it up for questions, comments about this initiative and the participation. If we'd like, sure. And please go to the mic. We want to record everything here, so please don't be shy. Yes, indeed, you're overwhelmed.
Still half asleep.
I'll throw out a question because this is a wealth of great information, and I'm kind of actually a bit overwhelmed in that this is great work and moving the whole concept of doing research forward in ways that are so meaningful to the whole audience. But I am trying to wrap my mind around, and actually I'm grateful for an overview of this research that I need to look back on, how it is that we move forward, I guess, and maybe I can ask some next steps that you see in your respective areas, and particularly in regard to this last issue that is a concern to mine, that is data acquisition and how to best acquire that in situations where I am in particular interested in the surveillance of issues going on in a country perspective. In other words, trying to get information from the entire country. So maybe I can throw that out to you.
So the first point was, where do we go from here? And this is really a very important question, because publishing 4 papers or 5 papers is one idea and outcome, but that's not enough. I'm sort of as a researcher in emergency medicine, I define success as NIH potentially announcing a focus on emergency care research and LMICs as a program, potentially putting in some money. So one of the outcomes we are looking at is, once we have these papers done, perhaps launch them in a way that there is more presence of other NIH institutions, other funding agencies, and there is more focused announcement. Right now, if you look at NIH program announcements, they're usually embedded within other fields, such as trauma or NCDs, and sometimes it's difficult for emergency medicine or emergency care to compete with the more established research groups. So that will be one broad idea success for me. On the surveillance, I think that is a critical question of how many countries today collect data in the emergency department that is available to the rest of the world. And it is so highly variable in many countries today, and there are other experts here. Emergency department data is considered outpatient data, is not captured anywhere in the health management information system. And I think WHO is trying to change that. And hopefully, I think in the next few years, but it'll take a few years, if we let the governments continue their track. On the other hand, if there is some money from NIH or other places, we can bypass some of that time period and start working individually with individual researchers in the country. So right now, I don't know, Emily or Adam, you have any thoughts on getting the data, but I'm not aware of any system right now.
Yeah, well, I'll just say a lot of our emergency care research that we've been doing in Rwanda is basically registry data. It's data from that we've created from medical charts. And part of, I think, one of the things that we also need to be advocating for is, as we push for development of emergency care systems in different countries around the world, we need to push for that data collection component of it. It may not be the sexiest part of emergency care, the medical records, but I think that's a really important and key piece, because if data is being collected clinically in these departments in a good and sound way that can then be looked back at, there's a wealth then of information that we have available to us that we can use from a research perspective to try and advance care. But if the data is never being collected, then it's never going to be available to us. So not only is good data collection good for patient care and for the individual patient, it's also really good for emergency care research and the global EM community as a whole.
Maybe I'll just make a quick comment. 2 things. One is that there's the registry component that Dr. Razak talked about, and then there's this surveillance issue, right? Like, so kind of what's collected routinely by HMIS, and then kind of what does that mean in the context of registries? To speak to the registry specifically, I was just at WHO last month. They have literally 3 weeks ago launched their trauma data registry, which has a dashboard that is available to countries and a standardized clinical chart that goes with it. So there's a standardized medical chart and trauma chart that captures all the minimum data set fields for a standardized trauma registry. That the intent of that is to actually expand that to medical complaints as well. So you essentially will have an emergency care data set that's been developed over the last couple of years' time. That is available kind of in an online platform by which we can access. This is the intent, but it is brand new, right, and just rolling out now. So I think that it's very hopeful moving forward for kind of how do we get that data and where can we extract it from.
Please.
Hi guys, thank you for that exciting presentation. It was great to hear, I think, a lot of the logic behind the frameworks, and I know many of you guys. I think one of the things I struggle with in our partner sites in extracting data out of emergency rooms is the emergency room becomes like the short stay unit, the long stay unit, the capacity overflow, the ICU, as you all pointed out. Is there any work around defining that emergency care period? Because I feel like for us, we're struggling to tease out what's mortality because of our initial emergency care versus what my own home institution in the U.S. does poorly is boarding patients in the ER. And so I think it becomes this very tricky, what's the end point to measure the quality of our care? So I don't know where the discussions have been on that, or if you're using any particular guidance or any data collection methods you've seen that are useful as we're building data systems in a couple of my partner sites.
So, I mean, our working group on clinical research, at least, has been discussing this and what is the sort of time frame of emergency care research. And, you know, in similar discussions in the United States, you know, the first 6 hours of care has been really posited as the time period of emergency care research. We decided that in a low and middle income country context, it made more sense to extend that to the first 24 hours of care because of the difficulty in people even reaching a healthcare system in time. And so it's a very arbitrary number, but that's sort of what we're looking at, and, you know, hopefully going to be encouraging as a time frame to look at when you're talking about interventions and considering those emergency care interventions. Those are the ones that are delivered in the first 24 hours of contact with the healthcare system.
Yeah, we actually, for the clear, in the initial discussion, we said 24 hours. Now, there's no right answer, right? Is it 6 hours, 24 hours? But we had to draw a line somewhere, and we thought 24 hours was the right time. It's so difficult, but again, without that, it's really difficult to say where are we successful or are we failing, and we have not done that so far. But for clear, we are using that timeline.
Please.
Hello. Thanks for a very interesting discussion and some great definition of the problem at hand. One question I had, and I'll say this, it's somewhat selfish because this is where my research in the global context has been, is how do we better collect data on the software issues, those power differentials, as well as patient perspectives that really do influence utilization of newly implemented emergency care perspectives. Unfortunately, that's not something we can get from our registries or even from our EMRs, and how do we move forward in that area of research?
Thank you for raising that. That's actually an issue that's pretty near and dear to my heart right now. And trying to figure out how to do that work, right? And I think that's really crucial because we don't know what we don't know. And it's, you guys know this as well. Like when you sit down in a country that you're working, you actually ask the patients kind of like, what are your barriers to access? They come up with stuff you have never thought about, right? And so I think one of the things I think the health system group really wants to do, especially in the recognition of non-traditional systems, as well as how patients access care, is really emphasize that piece in like the paper that comes out in order to be hopefully try to push, right, NIH to consider funding some of those things. But they do come from very different sources, and prioritizing essentially anthropologic, right, and kind of community-based surveys with focus groups and qualitative research, that's going to be the answer, I think, to getting to the answer to some of those questions.
I think we are
Pretty much in time. Again, thanks everybody for joining us this morning for this discussion. And again, reiterate some of these questions and the elements of our presentations are applicable to neighborhoods of Indianapolis as they are in neighborhoods of other cities or other countries around the world. Global health is local, global, and some of these questions that we are grappling with here in the United States are applicable to our initiative here with low and middle income countries. So let's not forget that definition, if you will, and that priority of understanding these challenges and applying research methodologies to answer them as appropriate. So again, thanks everybody. Thanks for the panel, and have a great rest of the day. Thank you.
Thank you.